Oh, we have a lot of those who we. Hello.
It's Angela is connecting, and Angela is the chief of the students, so she. I was contacting her if they were having any problems.
If Angela, I think Angela is here.
Angela is here, but there are two more students.
Okay.
And she told me she's connecting, but she's in contact with the other two, so she will give us updates if the others have problem. And then there's Piero. Piero's okay.
So we are here. Okay, there is one more.
Piero is coming.
Piero is coming. Okay. Yes, Angela told me that the other students are connecting right now.
Mm-hmm. Yes, there is someone else. So now we are 7 participants.
Okay, Giulia, Angela, and Luca are the students. Mattia, and because I think you can do it. And
You see those who are here?
And Piero, one of the residents is missing. The others, the 3 students are here, and because the thing is that we don't use Zoom so much, so yeah, sometimes it can be tricky.
Zoom here. Okay, there is one else. Raluca or Raluca?
Yeah, Raluca is another student.
Okay. And one more is coming, 1 plus 60. So we are 8.
So I guess we are, who is 1 plus 60? A hacker.
No, I don't think the hacker would be interested. There's more.
Data extraction.
Then. So how many are missing?
We're 5. So 3 students and the 2 residents, and 1 resident, Mario, but I don't know if he's able to connect. I don't know who is 1 plus 60 actually.
1 plus is Piero.
Ah, Piero. Is Mario coming?
I don't know.
You don't know. Okay, in case I mean as.
Oh yes, Mario is here. I'm admitting him.
Okay. Ah, so you have to admit everybody?
Yeah.
Ah, okay.
So I admitted 1 plus 60, despite the fact.
Okay, I think once Mario is here, we can, I guess, start.
Okay, Mario. Do you see the attendance or no?
Do I see what?
Those who are the participants.
I can see the participant, so it's me, you, Mario, Angela, Mattia, 1 plus 60, and Giulia and Raluca is gone?
Yes, they
just wait a few seconds.
Or maybe they.
Giulia has a bad connection, this I know, because all the times we do lessons, she's like coming and going.
Recording. In case if someone cannot participate, we can send them the video.
We can record it.
Yes. I am recording from now because now I'm scared to stop it. Okay, there is Rossetti.
Giulia, yes, but Giulia will come and go all the time.
Okay, so what do you feel? Should we start or we?
Yes, we can start. So, I will introduce you in Italian. So, just to give, first of all, welcome and thank you for coming. Ragazzi, vi presento la dottoressa Sabri Nazim, che lavora al Ras Al Khaimah Dental Hospital come professore associato ed organizza una serie di corsi per chirurgia orale presso l'Università di Baku nell'Azerbaijan. La collega dell'Azerbaijan, you're from Azerbaijan, and I said you are working as associate professor in the Ras Al Khaimah Dental College, and you organize courses in Baku at the Azerbaijan University. And oggi ci parlerà della sua esperienza con le estrazioni dentarie, and you will talk about dental extraction and your experience.
Yes.
I guess we can start.
Okay.
So
everyone,
it's
hello.
your time now, Sabrin. Thank you very much.
Thanks to you. Let me then start sharing, and just let me know in case if you cannot see my screen or there is anything. Okay, I think now it's very clear. So first of all, thank you very much for inviting me. It's actually a pleasure, and it's my honestly first experience to give a lecture or discussion to Italian residents and students. And me and Dr. Sapanaro, we actually had a training together in Vienna, in Austria, in the biggest hospital there. And this is my some of the photos from my training and organizing some of the trainings for the students, MOUs and etc., which already Dr. Sapanaro presented. Let us go for today's information. So I'm planning to speak about surgical extraction of impacted teeth. And as you can see, those are the learning outcome that I will try to cover. However, due to time limitation, I will not touch canine impacted canines, maybe because the third molars itself is a huge topic. So let's start first of all with, I'm sorry. Okay, let's start first of all with an anatomy because I know that you are already, some of you are already surgeons, you have a great knowledge about the anatomy, but I would like to emphasize the importance of the anatomy because it's not only for a proper incisions, however, it is also helping us to prevent some of the complications and also to manage some of the complications. When the patient will come to you, the first that you have to be able to explain to them what actually means to have an impacted tooth, because a majority of the patient, they don't have any idea about that. So first of all, you need to know that an impacted tooth is one that fails to fully erupt into the dental arch within the usual range of expected time. This is first what you will explain to them. And then second, you have to also highlight that the tooth becomes impacted because of different reasons. One of them is abnormal tooth orientation, adjacent teeth, dense overlying bone, excessive soft tissue, or even a genetic abnormality which can prevent an eruption. There is a general rule for all, so you have to know that those impacted third molars or impacted teeth should be removed unless there is a contraindication for that. So first of all, removal of impacted teeth, just for your knowledge, once the patient becomes in advanced age, it will become much more difficult to perform this extraction, especially surgical extraction. And if the impacted teeth are left in its place, then it will create another problems. The patient might experience an increased incidence of local tissue morbidity, loss of damage to the adjacent teeth and bone. There can be even potential injury to the adjacent vital structures as well. So some of the patient will come to you with the common symptom, which they will highlight that I have the ear pain. So you will think, how can it be related? Actually, the impacted third molars, they can irradiate the pain wherever they want. So you can see here, as I highlighted in this demonstrated picture, that it can give a bad breath, it can give a pain, swelling around the wisdom teeth, swelling glands as well, and even a pain, as I said, in ear. Also, they can sometimes highlight that they have a pain in their head. what can be the causes of the impaction? This is the most important question. There is a systemic and local causes. So for the systemic, as you can see, I will not stop in all of them, of course, since you are medical residents and students already. So you know already about the Down syndrome and the other ones. But local factors are very important. For example, if there is prolonged deciduous tooth retention, or if there is malposed tooth, or if there is arch lengthy deficiency, so if there is no enough space for the tooth to erupt. And then odontogenic tumors can be a reason. And definitely my favorite is cleft lip and palate. Also, it is one of the reasons. So if you look at this picture, it clearly shows that yes, there will be a different abnormality in oral cavity, and definitely there will be no enough space for a proper eruption. And this is what can cause the impacted third molars. But the most important, I guess, is how can we evaluate the impacted tooth, since we cannot see it, right? But what can be the, what evaluation can help us here? So for example, clinical evaluation, which will be delayed eruption. So if you have noticed that there is a delayed eruption, so you can understand that, yes, there might be impacted tooth. If there is a crowding, so sometimes if there is a crowding, for example, the orthodontist, immediately they will tell you, let us have the radiology, and they will find out suddenly that there is an impacted third molar, for example. And radiographic assessment will definitely help you. Here, it doesn't have to be only 3D CBCT or computer tomography, but panoramic views and lateral cephalogram is also very helpful. And let us see here, for example, this is not a 3D and this is an OPG, and it clearly shows, for example, the impacted canine. Then in the OPG, orthopantomogram, here you can see even 4 third molars are impacted and in different positions. But 3D is very perfect. Why? Because you can see here, for example, the anatomy is very important, especially for surgeon, because once I'm planning to do any surgery, I need to know if I will damage any of adjacent structures, as you know. So here, as you can see, the nerve is very close, for example, and as well, it will also help you to give an information for your patient in case you are, you might have any kind of complications during the surgery. If you will be interested in how to localize the impacted canine, I would suggest you to read this article, but I don't want to stop here. So this is the periapical radiograph. As you can see, it is also helpful, to be honest. So I'm again emphasizing the point that not necessarily that we go to CBCT. In fact, that is also very good. This is the different views that we can have: lateral cephalogram, occlusal radiographs, and 3D techniques, which I said. And 3D techniques is, of course, the perfect one. As you can see here, for example, you can rotate the radiology. And I think someone wants to, I have to admit someone else. Yeah. Okay. So as I said here, for example, you can see the impacted canine, you can rotate it, you can see exact location of it. We have also rapid prototyping, and I'm pretty sure that you are using that in oral maxillofacial surgery. This is very helpful. STL, we call it, right? Also. Let's go to the very interesting part, which is what is the indication for the removal of impacted teeth? Because we don't do the surgeries for anyone, isn't it? So due to that, first of all, let us understand how it will help us. So it will prevent the periodontal disease. Then it will also help us with prevention of dental caries. So if you see on this third molar, it is very close to the adjacent tooth, to the second molar, and definitely it will create a problem for the adjacent tooth. Prevention of pericoronitis. So I guess you are aware of what is pericoronitis. And then prevention of the root resorption. Because sometimes the location is very deep of third molar, then what will happen? It will start to destroy the adjacent root of the tooth, which is very bad. And prevention of odontogenic cysts and tumors as well, as you can see here, for example. Because it was left there for a long time, due to that, it just started to grow. This is the problem. What else? I need to highlight the role of impacted teeth under dental prosthesis. So you need to know that, my voice is clear?
Yes, yes, I
Okay.
think so.
Okay, great.
Gli altri sentite tutti quanti bene?
Yes.
Okay, thank you. So regarding the teeth that are under the dental prosthesis, so you need to know, because some of your patient who will come, they will be in an advanced age, or even a young patients who are using a dental prosthesis. So definitely if you find that there is an impacted tooth before proceeding to the dental prosthesis, even if the patient is referred to you by a dentist, you need to confirm with him that he definitely needs to extract this tooth first of all. All right, because during the extraction, we are removing the bone. It is a surgical extraction, and definitely it will create another problems. And if the patient sometimes comes to you with an, with a pain of unexplained origin, so you will think about the myofascial pain dysfunction. Let me just add Piero also. Okay, I have added. So, for example, you might think that it might be a myofascial pain dysfunction syndrome, but if you decide that no, it is not, and other facial pain disorders are excluded, and if the patient has an unwrapped tooth, then definitely you will go for the extraction. Why? Because maybe with that, it will resolve the pain of the patient. Okay, also the facilitation of orthodontic treatment. As I mentioned already, that sometimes the orthodontist himself will refer a patient to you for the extraction because there is no enough space, there is a crowding, and the only reason for that is an impacted third molar or canine. It can be any of impacted teeth. What is interesting that we need to know the contraindication, because sometimes we really need to defer the treatment or the surgical extraction. So actually we understood that all impacted teeth should be removed unless there is a specific contraindication which will justify for you to leave those in their own position. So if you look at what I wrote here, when the potential benefits outweigh the potential complications and risk, the procedure should be performed. This is what we need to understand. So the contraindication for the removal of impacted teeth primarily involve the patient's physical status. This is very important. For example, extremes of age, and then we can have a compromised medical status, and you know who are the compromised patients, if they have a heart disease, if they have, for example, diabetes or any other disease, which will ask you to delay the procedure. It doesn't mean that you don't have to perform it at all. And then if you know that there is a probable damage to the adjacent structure. So as I said, for example, if it is very close to the nerve and you know that you will definitely damage it. So if there is a possibility to leave it there, it's better to leave it there. Otherwise, there is other techniques how you can extract it. So coming to the classification, there is really 100 classifications, a lot of classifications for the mandibular, third molars, and maxillary. And just what you need to understand that actually the majority of classifications are based on the analysis of radiographs. So OPG, periapical, computer tomography, and classification concerning the angulation or the relationship to anterior border of the ramus and relationship to occlusal plane. So, and this is, you can see, for example, we have Pell and Gregory classification here. We have Winter classification. So there is a lot of different, but in the end of the day, as you can see in the last row, that, for example, this is very clearly shows us, for example, the first picture shows the vertical, and then the mesioangular, and then the horizontal, distangular, buccolingual, and others impaction, according to the classification. This is how looks the maxillary. Third molars classification. This is according to the Archer, and as you can see, it was created many years ago in 1975. So now when we come to the surgical procedure for the removal of impacted teeth, this is the lecture contents. So first of all, we understood already that the proper radiograph and the clinical evaluation should be done. This is the first what you have to do. And then the classification of impaction will help you to plan the surgical extraction for sure. Also what it helps you, if you will go with the worldwide classification, if you will have a discussion with your colleagues, definitely it will help you as well to to classify or to explain what are you talking about. And what is very important, the selection of the proper time for surgical procedure, because some of the doctors or even the young doctors, they like to tell their patients that don't worry, the procedure will be done in 30 minutes, everything will be perfect. But if you will look into the surgeons who have a little bit of experience, they definitely know that any surgery can be prolonged, isn't it? At the same time, you know that there might be any kind of complication. So due to that, always inform your patients about the timing and that they should not, plan anything else for the same day. The condition should be clearly explained to your patient in a very simple and easy way. You have to direct his attention to possible complication, as I mentioned earlier, because it might arise later on if in case you will leave the tooth there. As well as you have to also highlight the complications that might happen during or due to the extraction, the surgical extraction. So we should understand that it's not necessarily to do this surgical extraction under the general anesthesia, but believe me, it depends on the, the experience, the country that you're working in. So it's totally different, of course. But it can be done under local anesthesia and under general anesthesia as well. Some of the patients are not very cooperative, to be honest. So this will be also one of the reasons to go for the, sedation of the patient. And sometimes if you're not going to extract only one, then it will be a multiple surgical extraction. Definitely, again, you will have to go to the surgical, to the general anesthesia. So regarding the armamentarium or the instruments that you are going to use, so I'm pretty sure that scalpel is not something new for you, but what we will have to add here is the burrs and then the bone burrs. And again, to highlight, it is exactly the surgical procedure. So your PPE is very important here, because this is the reason, one of the reasons for the, complications after your surgery. So there are the factors that can make your surgery easier or difficult. So let's just highlight some of them. So factors that will make impaction surgery less difficult, so which means easier, it is if the patient has roots 1/3 to the 2/3 formed. So if it's not really formed, if it's fused conical roots, if it has wide periodontal ligament or large follicle. Also, it's very important that if it is separated from the second molar, definitely it will make your surgery much more easier. And if it's far from the inferior alveolar nerve, we will be very happy about that, and we will definitely tell our patient that it is going to be easier, of course. And soft tissue impaction, which is definitely will be easier. Now, what is going to create a problems for us, and what we will call that it will make our impaction surgery more difficult. So if you have seen already the classification. So if it is distangular, I will send you, by the way, this PowerPoint presentation, so you can go back to some of the slides in case if you want. If it is a long and thin roots, because if it is really long and thin root, it means that it is very prone to be fragile. If it is divergent, again, it might, break. There might be a fracture. If it is dense, if it is already contacted with the second molar, very close to the nerve, and if it is a complete bone-bone impaction. So again, what are the most commonly impacted teeth? So you have to know it, because if the patient will come to you with for example, with the upper third molar, which is impacted, so you will say that don't worry, it is the common situation. So the upper impacted wisdom tooth and the lower impacted wisdom tooth are the common one. Now, when we speak about the surgical procedure, so here you can see the first step is to have adequate exposure of the area of the impacted tooth. This is first what we will have to do. Then the second step will be to assess the need for bone removal and to remove a sufficient amount. So you will understand for yourself, do I really need to remove from the bone, or it will be pretty easy to do it without the bone removal? Because for the patient, definitely, as minimal invasive you are working, it is much better, of course. Then when we go to the third step, so you will decide if you really need to divide or section the tooth or no. Because again, it will help you to make your surgery easier. We have here a fourth step, which is to deliver the tooth from the alveolar process within the appropriate elevators. So you will know which instruments you need to use here. And the fifth step will be the bone in areas of elevation should be smooth with the bone file. So this will also help you to prevent some of the complications that might happen. You should keep in your mind that a better instrumentation and a higher degree of surgical skill is very important, of course. And honestly, majority of this is, as per my, experience, I could see that it frequently requires a sectioning, and it will help you a lot to make the surgery easier. And then the great amount of a bone should be removed, unfortunately. There is a different flaps that we are using. So for example, you can see here, reflecting, just one second, I will close those reminders. Okay, so we have here, for example, horizontal or envelope flap. It is actually easier to close, and also it will be easier, better healing will be there, of course. We have triangular flap. When do we use it? Actually, when it is deeply located and you need to go very deep and remove a lot of bone. So definitely triangular flap will be much easier for us here. Coming to the incisions that we are recommending for the extraction of maxillary third molar. So envelope flap will be perfect, and triangular flap as well is perfect here. As I have highlighted already, you can see again that the step 2 will be a removal of overlying bone. Right, so the bone on the occlusal aspect and on buccal and distal aspect down to the cervical line of impacted tooth should be removed, and you should not remove it from the lingual aspect. This is very important, and again, if you remember, we have highlighted the importance of the anatomy, because in case if you are going very posterior area to the very posterior area to the lingual side, then definitely you will damage a lingual nerve, as you know. If you look into the upper third molar, so in majority of the cases, we really don't need to remove the bone. So then the second step, we said that the proper instrumentation is very important. So you can see here, for example, we are using the straight elevator. Okay, but as I said, in some of the cases, it's not that much easy. We will need to do the sectioning of the tooth. Now, if you see the point 2, tooth is sectioned 3/4 of way toward the lingual aspect to avoid, again, the injury of lingual nerve. You will see in the complication part that why do we need to do that? Okay, and the fourth step is, of course, the delivery of the sectioned tooth. So as you can see here, so again, this is the sectioning, the crown from the root, okay? And you don't go very deep. You will help yourself in the end of the day with the elevator to just sectioning, so you don't go very deep, to the nerve area, to not damage anything there, to not injury actually. Then it will be very easy for you, as I mentioned here, the separation of the crown from the roots. Then when you want to extract the roots from inside, you will need to use not the straight elevator, the crier, as you can see. I believe that many of you do know what is this instrument. So the crier elevator will be helpful here. So now this is another case. For example, again, we have to section the area, the tooth, but you can see we are sectioning also the crown, not only the crown part from the roots. It gives me a reminder that in 10 minutes, this will close. In case if it will close, then we will go to the next one, the link that I sent.
Okay.
Okay. And then it will be much easier for you because you will divide it and then you will just extract it separately, and this is how it will look like. Okay, but honestly speaking, in a majority of the cases, what happens, it doesn't come like this because we don't section them that much as it's needed. And sometimes we really have to go also for the, one more sectioning of the crown from the roots again. So it will be, sectioned into 3 rather than 1. Okay. So if we will have in a distal angular position, this is the same story, but if you will notice here on the picture A, it clearly says here that you will remove only a part of the crown, so not the full crown, because once you will try to elevate the tooth, it will be stuck to the bone. Okay, so that's why you will remove just a part of the crown, and it will be much easier for you to extract it. And we said from the beginning that as minimal invasive we are working, that's much better for our patients. So if we try to remove less of the bone and less of the tooth, that's much better, of course, for our patient. Now you know that some of the patients will be edentulous patient, and those who doesn't have any teeth in their mouth. And at this point, again, if you remember, we have highlighted that if this patient is going for a prosthesis, so definitely we will have to finish first with the surgical part, right? And that's why I wanted to highlight some of the points. So, you know, when you are dealing with the patients who are edentulous. So this surgery is actually much easier and faster compared to the dentulous patients. And this technique for creation of the flap and removal of bone are the same, actually. Again, it's just giving me a reminder, sorry. And the second molar is often missing, and therefore tooth sectioning is not necessarily. So, you know, that's making our surgery much easier. Okay, this is the extraction of impacted maxillary third molar. If you remember, I have said that it's not necessarily that we always remove from the bone if we are extracting the upper third molar. But we already highlighted which kind of the flaps are perfect here. So for example, you can see a triangular flap. You can see how looks the impacted tooth. It is very close to the second molar as well. So definitely, and it is also deep, for example. And this is the horizontal flap, for example. So here the buccal bone will be removed until the crown of the impacted tooth and part of its root will be visible or exposed. And then you can go for the luxation of the tooth. So this is how it will look like. Here we are using the elevator and we are just luxating it. Now I know that especially in Italy, you love piezo surgery. I have heard it first time from there. I'm not sure if you're using it at the moment or no, but you know that it is a good surgical technique, and it is used based on the piezoelectric ultrasonic vibration, and we do use it for the extraction of third molar as well. So let's see, first of all, what is the advantage of this piezo surgery device over the conventional surgical equipments? Because, you know, in majority of the countries, to be honest, we don't go for piezo surgery, but still there is an advantage in that. So compared with the traditional way, piezo surgery will require much less hand pressure, which is very important. It will have a cut very safe. And then it is less invasive, of course, and due to that, the healing process will be better. And during the surgery, for a surgeon, it's very important to work bloodless, you know, so you can see clearly all the area that you are working in. And due to that, it will be very clear for you. Okay, and then it will reduce.
But it's also very slow.
It is, yes, it's slow, but
it's very slow.
I know that, I know, yes. But still, there is an advantages, to be honest. And
do you use it? Do you use it regularly?
We use the regular technique. We don't use the piezo surgery.
Okay. No, we don't either for dental extraction. For some other things we do, but for dental extraction, not in our clinic at least.
Okay, but I mean like surgical extraction. Even for surgical, you don't use it.
Mostly for like when we have to go very, very close to the nerve. Okay. For like bone flaps or bone removals close to the nerve or close to the dental roots, then we might use it. But for unless it's a very complicated extraction, we hardly use it because it takes a long time and it's only available for us in under general anesthesia. Because we don't have it on an outpatient. So
yeah, and we are the same, but in the end of the day, everyone has to be informed about the different.
Yes. No, I was just curious about it.
Yeah. Okay. So this will reduce also the risk of postoperative necrosis as well. So if you are interested in that, you can read this article. I will not continue here, but I don't know. Maybe I should stop and we go to another link because I'm.
No. It's interesting. If we have time, we can see it.
I mean, like if this link will stop, I think it will close.
Okay.
So should we go to the second link so we don't have we don't experience?
All right.
Okay, great. Okay.
Allora, ragazzi, c'è il secondo link, perché purtroppo Zoom dà soltanto mezz'ora, half an hour.
Yes, okay.
Quindi se andare sul secondo link, continuiamo lì, perché questo video dura un po' di più.
Okay, I'm going to the second one.